What guides gender medicine?
What this field of medicine really is, what guides this field of medicine? Because I'm telling you now, it's not evidence and it's not science and it's not first do no harm. It's ideology and then more ideology and then autonomy as its guiding ethical principle. If the patient wants it, the patient should have it. Nothing excludes the patient from getting what they want in the form of hormones and surgeries.
Concepts with Shawn Whatley.
Welcome to Concepts. My name is Shawn Whatley. Today we have Mia Hughes with us. Mia is director of Genspect. It's the Canadian branch of an international organization focused on gender medicine. She's a writer, a researcher, a journalist, and she's given seminars at Stanford University. So, very busy person lecturing around the world. She came to prominence when she wrote an expose on the WPATH files, and we get into that in our discussion. We start out talking about WPATH specifically. It started out as a medical care forum, a group of specialists initially getting together, trying to figure out how they could approach treatment for people with gender dysphoria. But then it morphed into something else. It was taken over by activists and people who weren't so much excited about the medicine and the clinical science, but who were really focused on advocating for transgender medicine as an area of activism. From there, though, I really tried to play devil's advocate and say, well, wait a second now, are you trying to say that we get to decide what patients should have? Medicine has a long history of doing some really bad things to patients. Forced sterilization, the Tuskegee experiments, the syphilis experiments, the behavior of the medical profession during World War II. Medicine can do some really terrible things to patients. And so I challenged her. Maybe trans activism came about because doctors treated people poorly. And so she gets into that. She answers it. We had a long discussion about the moral high ground in patient care with respect to forming a differential diagnosis, asking people questions, not simply saying, oh, that's your diagnosis? You're telling me your diagnosis? Okay, great. We're going to run with that. So we had a long discussion there as well. Ultimately, a lot of this comes down to how do we see ourselves in society? Are we a consumerist society in which the customer is always right and the customer can ask and do whatever they want? If something is technologically possible, should people be able to access it? So we get into a discussion about medical ethics and what does it mean to do no harm? What is harm when it comes to gender medicine? And then we get into also a deep discussion about the evidence itself. What does the data show? Are people actually benefiting from having these hormone therapies and surgical procedures? Or are they in many cases coming to harm? And then we end the program talking about Gordon Guyatt. I can't emphasize how important this physician is. He's the godfather of evidence-based medicine. Certainly during medical school in the 1990s, the number of times we heard Gordon Guyatt says this and Gordon Guyatt says that, and all the evidence-based people at McMaster say whatever. And certainly they were world authorities on this new approach to thinking about medicine and about evidence. And so much of it is good. I'm not trying to discount all of it, but we turned evidence-based medicine into a hammer, and everything in clinical care became a nail that we were going to hit with evidence-based medicine. So she actually had Gordon Guyatt on her podcast, and McMaster University I think they made a mistake by coming out and saying how wonderful the evidence was for gender medicine, despite the fact that the evidence is actually very poor. And so she challenged Gordon Guyatt on that, and he got actually very angry, and he said, no, who would ever say that? And so she read back to him what he actually had written, and he didn't apologize. He said, oh, well, that probably wasn't referring to the part that I wrote about it. So it's quite a fiasco. And there are viral videos about it, about him saying what he did. And all this to say that this whole issue speaks to core concepts about what we think humans are what is medicine, who gets to decide the limits of what we can and should not do in society with respect to medical technology here, but to technology more broadly. So I had a lot of fun with this discussion. I hope you enjoyed as much as I did. Please take a moment to click like and subscribe. It doesn't cost you anything, but boy, does it ever make a big difference to the show. And consider becoming a Patreon member too. That would be a huge, huge help for sure. Let me know what you think. I look forward to your comments. Let's get on with the show. Welcome, Mia Hughes.
Thank you for having me.
I appreciate you making the time. In the green room, I think we took longer than usual because I was saying, okay, if you say this, I might get in trouble. And if you say that, I might get in trouble. And so I needed to start by complimenting you on, I think, to me anyways, it seems like what you're doing is very courageous. You're a whistleblower on the WPATH files.
That's correct. I think the conversation we just had is you're framing me as courageous, but isn't part of courage when you have very little to lose? It's easier to be courageous. And I'm not a registered medical professional. I don't have a career that is in jeopardy because of what I say on this issue. My entire career is built upon commenting on the scandal of gender medicine, the scandal of pediatric gender medicine especially, and the terrible fraud of WPATH. So perhaps it's courageous, but less so. It's less of a risk for me.
Yeah.
So would you like me to tell you about WPATH files to start?
I would, but I would also disagree with you. You're being very courageous. You still have a life, and you could still get attacked. And we're going to get into that probably deeper in the conversation. We'll hear about some of the mud that's been thrown at you. But please, yes, tell us the WPATH story.
Okay. So I was, let's see, this is 2023. I was a reporter for the Post Millennial. I was covering the gender issue for the Post Millennial when I wrote a Twitter thread that Michael Schellenberger really liked. It was a thought experiment comparing trans to people who want to be amputees, people who identify as amputees. There's a parallel disorder there. Michael Schellenberger really liked it, offered me a job just based on that Twitter thread, and I took the job. And as soon as I started writing for Michael, which was obviously writing about gender, he was given a stack of documents that were leaked internal communications from the World Professional Association for Transgender Health. They are now known as the WPATH files. So Michael had just come off doing the Twitter files. And so he gave me this stack of documents. And, part of it, I had been talking about WPATH. I had been researching WPATH, writing about them for a number of years by that point. And so I was already obsessed with this group. Because I was obsessed with the medical scandal, and in order to understand the scandal of gender medicine, you have to understand the group that sits at the center of it, and that is WPATH. So I got this stack of documents, and it was kind of challenging. We tried to turn them into a series of articles, first of all, and it just, 6, 7 attempts completely failed, and then Michael moved me over to his nonprofit, and I wrote a 70-page report. And the beauty of it was, because the documents were so wide-ranging, they're in their forum, it's internal, and they're just WPATH members talking about difficult cases. They can be mental health professionals or endocrinologists or surgeons, and they're in there talking about difficult patients that they have, and then the entire forum swoops in and gives advice to this professional. And the thing that is unique about WPATH, it's supposedly a medical association, a professional association, but it's a hybrid in that it has medical professionals who practice in the field of gender medicine, but then it also has activists, very hardcore trans activists. They can be human rights lawyers, they can be just activists, just really hardcore activists. And they're all mixed together inside this association, this medical association. And so they're also all mixed together inside the forum. So somebody will pop up and say, oh, I have this individual, it's, it'll be a male person, and they have major depressive disorder, schizophrenia, all of these long list of serious mental health issues. And I don't really know what to do. This person wants estrogen. And then there's just a chorus of WPATH members saying, oh, that's fine. There's no reason why you can't give this person estrogen. And, oh, I gave a homeless person a referral for castration and they did just fine. And another one shows up and says, the only person I've ever turned down in my entire career is somebody who is in active psychosis in the appointment. And so what was wonderful about it was you can just see the culture of WPATH. And because the culture of WPATH is the culture of the entire field of gender medicine, it was a way for me to tell the story, tell the world what this field of medicine really is, what guides this field of medicine. Because I'm telling you now, it's not evidence and it's not science and it's not first do no harm. It's ideology and then more ideology and then autonomy as its guiding ethical principle. If the patient wants it, the patient should have it. Nothing excludes the patient from getting what they want in the form of hormones and surgeries.
So as you're saying that, first of all, my skin is, I'm just, I didn't know all this even, and I should know it. I am embarrassed to say I don't know it. But it reminds me of what we do in medicine all the time. So, for example, we'll have tumor boards, or I spent a long time in surgical pathology. I was in head and neck surgery, and we would do pretty much exactly as you're describing. We would bring together a group of specialists. We'd have the surgical pathologist, anatomical pathologist, so people who are good at looking under the microscope, people who know the epidemiology of a particular cancer. We'd have several oncologists, people who are experts on giving drugs, radiation oncologists, people who are experts in radiation. Anyways, you get the idea. Social worker, counselor, internal medicine. Mostly it was sort of more on the technical side of things. But we would do exactly as you're describing. We would present difficult cases and say, this is what we have. We have a recurrence. We're not really sure if this tumor is X, Y, and Z. These are the reasons we think it is a particular thing. And then we try to work out a treatment plan together. So it sounds like you're sort of describing that. And it makes me wonder, was WPATH always so activist, or did it actually start out with more of that medical focus of, here are the physiological things that we're dealing with? So was there ever a better form of WPATH in the past?
That's a good question. I love that question. So WPATH, before it was called WPATH, it was called the Harry Benjamin International Gender Dysphoria Association. It formed in 1979. And at that time, it was professionals, first of all. It wasn't activists, because transactivism didn't exist back then. So it did consist of a loose affiliation of professionals working in this very fringe field of medicine that almost nobody wanted to go near. These people had no idea what they were doing, and they would come together and try and figure out what to do with these patients for whom the disorder, they didn't even understand what the disorder was. They knew really very little about it. And there's a very interesting thing about it, even then, though, is that it was funded by a woman called Reed Erickson. It's named after Harry Benjamin, first of all. So Harry Benjamin had helped this woman, Reed Erickson, transform into what looks like a man. She was one of the early transitioners. And Reed Erickson was very, very wealthy and poured a whole ton of money into Hibigda. It was called Hibigda. Poured a whole ton of money in, but was only interested in the medicalized approach. So Reed Erickson is funding the study of the medicalized approach for this group of individuals. There's no discussion about the psychological approach, the non-invasive approach. So in the early days, certainly it was weird, it was strange, but at least it was all professionals. And at least they could gather, they had their annual conferences, they produced standards of care. They know that they don't have any evidence. Then they're not even hiding that they don't have any evidence. They're just doing the best they can in a strange branch of medicine. But then the story gets really interesting. The story of gender medicine is entwined with trans activism. You cannot separate the two. And so 1979, when HIBIGTA formed, that's right when Paul McHugh shut down John Money's gender clinic. So Paul McHugh was a psychiatrist in chief at Johns Hopkins. He looked at the outcome of John Money's first wave of men. It's like, these people aren't doing any better. We're just colluding with a mental illness rather than helping people. And he shut the whole thing down. HIBIGTA formed at the exact same time. So then, because they lost their one gender clinic in the US, the main center, transactivism starts to form. But the goal of transactivism is to obtain medical treatment. That's the civil rights cause. It's not, they claim that it's an end to discrimination in housing, employment, whatever. It's not. Well, it's slightly that, but the actual goal of transactivism, first and foremost, has always been gaining access to these medical treatments. So transactivism launches at the same time that HIBIGTA is just getting off the ground. And then around the late 1990s, as transactivism is starting to really gather strength at this point, activists start to join HIBIGTA. You see that in the late 1990s. By the early 2000s, and we know this because a wonderful human being, Dr. Stephen Levine, was a member of WPATH at the time, HIBIGTA at the time, and he saw this shift. He saw the activists join, and he said, you would be at the annual conference, professionals would be talking about the poor evidence quality or the poor surgical outcomes, and trans-identified activists in the audience would start heckling these people, shouting them down, and this like kind of control of the narrative, control of what the professionals were saying, control about the talk about the negative impacts was starting to creep in even in the early 2000s. So then Dr. Stephen Levine left because he could see that the group was now being shaped by activism, not by science, evidence, or any kind of professional standards. And then throughout the 2000s, as transactivism is gaining strength, they're overrunning WPATH. So then WPATH it rebrands. In 2007, it goes from the Harry Benjamin International Gender Dysphoria Association to the World Professional Association for Transgender Health. And that's a huge change because look at the difference in the name. Suddenly, they are the world-leading professional association setting all of the guidelines for transgender health. It sounds really legitimate. They've just recreated themselves. And at the helm at the time was another woman on testosterone who thinks she's a man, who is not a medical professional. It's a woman called Stephen Whittle, a human rights lawyer or a human rights activist. That's who was at the helm of WPATH when it became WPATH. And then their entire guiding principle from that point on was pushing something called de-psychopathologization. And de-psychopathologization means you take something that has been labeled a psychiatric disorder, a psychopathology, and you de-psychopathologize. You turn it into something natural and healthy and an innate trait. They modeled it, of course, after homosexuality being removed from the DSM in 1973. Transactivism just used the same tactic. We're going to take the diagnoses related to gender, trans identities, and we're going to make them healthy. So that was WPATH's guiding principle from the moment that trans activists took over. And that's, I believe, the core of this entire medical scandal.
So again, I'm embarrassed that I don't know all these details, so I'm glad you're telling them to me. And again, as I'm listening, I'm thinking, I guess I'm trying to play perhaps devil's advocate and say, well, people don't just become born trans activists. Usually there's some point of frustration. Now, nowadays, I think it's more of a contagion phenomenon, but I'm trying to think, medicine's done a lot of terrible things. And we've had some really bad, like I've got on my shelf behind me, Nazi doctors, right? The medical profession in the Second World War was just horrific. We can talk about the Tuskegee syphilis experiments and forced sterilization, and I could just go on and on of all the terrible things that have been done in the name of science. So is there a chance that some of the early people studying gender medicine, I think we can assume that most of them were trying to do good work, trying to help, but were some of these people mean and nasty and just really creating an environment like what, how can we steel man the trans activist argument? What have they said that medicine has done that has been so terrible that required the growth of a whole activist movement? Or is there no argument? Is it just matter of an issue, like you said, it's all about patient desire? So is it just about them saying, we wanted to do something and you were blocking us? Or is there any merit to the notion that maybe medicine was being mean and cruel and nasty? Go ahead.
There's a lot there. I'll start with, first of all, what treatment was like in the early days. I would argue that in the 60s, we've got John Money, Harry Benjamin, Robert Stoller, Richard Green, that gang, and it's the sexual revolution. Anything goes. I would argue that, they received care. Individuals looking for this treatment received care based on no evidence. And there's a problem there. They've got no evidence and they're chopping penises off and they're chopping breasts off and they're pumping them full of hormones. That's a remarkable thing to do on the grounds of absolutely no science whatsoever. So I think it's remarkable that they ever had access to this treatment. What they did do, certainly in that time, was they would look at the man. It was usually men. They would look at the man and see whether they thought that he could pass as a woman. That was one of the criteria for qualifying for these treatments. And I don't believe they were doing that in a nasty way. They were doing that in you have to live your whole life. You have to go out, mingle with the world. You have to blend in with society. And if you don't blend in, your life will be difficult. And therefore, we don't think we'll be helping you. Trans activists or trans-identified people who wanted this treatment were very upset about this whole, you have to be able to pass. They felt that was discrimination. But then, you see, I don't know. I have a very complicated answer that I could give. Would you like a really complicated answer?
Go for it. Go for it.
This is the thing that I am obsessed with at the moment. I don't know if you've ever had this where I feel that I have cracked the code. I've been thinking about this nonstop for 6 years. And at some point about 2.5, 3 years ago, I felt that I cracked the code, and I've been working through my idea ever since. So why I think the field of gender medicine is guided by activists, why I think that the field of gender medicine and the trans rights movement pursues this hormonal and surgical intervention as its primary goal is because, nobody's ever really known how to classify transgender identities in a psychiatric classification. All the way through, there has been so much confusion. We don't know what it is: gender dysphoria, gender identity disorder, transsexualism, a paraphilia called autogynephilia. Nobody's really known how to classify it. And then I came across, it was Dr. Paul McHugh, actually. He's the man who shut down John Money, a brilliant, brilliant psychiatrist and a brilliant scholar. And he called trans identification an overvalued idea. And I was like, what is an overvalued idea? So I went into the psychiatric literature, and it's this concept that was originated in 1892 with a German psychiatrist, Karl Wernicke. And it's one idea all consumes an individual. The individual is of sound mind, Everything about their life is perfectly normal. There's no psychosis. There's no, obvious mental health issues. But one idea just all consumes them to the point of pathological behavior, to the point that they pursue something that is harmful either towards themselves or others. This is the overvalued idea. A crucial part of the overvalued idea is the individual does not see that they have a psychiatric disorder. It feels completely natural to them. It feels like a true expression of their most personal nature. That's what an overvalued idea is. And so Paul McHugh called trends an overvalued idea. And I realized that is what it is. These people are not delusional, because a delusion is idiosyncratic. Only you believe that aliens are communicating with you through the radio. Nobody else around you believes that. So you can't call it a delusion. You can't call it an obsession, because a person experiences obsessions as intrusive and distressing, and they fight against them. And that's not what this is either. And so the overvalued idea, it's experienced as pure and natural and a true expression of the self, and it all consumes the individual, and then they pursue what is absolutely harmful medical treatment. Having your penis chopped off is a form of harm. Having an appendage made out of your forearm sewn onto your groin is a form of harm. Having your breasts cut off. All of this is not medicine in the sense that it restores health. It's medical treatment that inflicts harm on a healthy body. And so the point about transactivism is it's made up of individuals, each one of whom is all consumed by this idea that they must achieve medical treatment. And then all of them come together and form a movement that is built upon this idea that we must obtain medical treatment. And another key feature is anyone who steps in the way of the person with the overvalued idea achieving their one obsessive fixation is viewed as the enemy. The person will lash out, they'll be angry, they'll be very frustrated. And so that's transactivism. The one goal is this idea, we must get these medical treatments. There's no other, there's nothing wrong with us. Well, we're healthy, it's a healthy identity, and we need these medical treatments. And then anyone who suggests otherwise is vilified and persecuted and demonized as being the worst possible person ever. That to me is why when WPATH, it was a group of professionals who didn't understand the overvalued idea because they didn't know what they were treating. When WPATH became overrun with individuals who are all consumed by this idea and are acting solely driven with one focus to obtain their goal, that's how we ended up. Because they succeeded is the remarkable thing. These activists joined WPATH, succeeded in launching this campaign, de-psychopathologization. It's all very healthy and we need this medical treatment. They got it into the American Psychiatric Association's Diagnostic and Statistical Manual, DSM-5. They get gender dysphoria. That diagnosis was de-psychopathologization. That diagnosis reframed it. Before it was gender identity disorder. So the disorder is the identity. Gender dysphoria flipped that. Now the identity is healthy, and the disorder is the distress that you feel because you have this healthy identity that doesn't match your body. And that opened the door to medicalization on demand for anyone who declares that they have this identity. But at the same time, the other thing that de-psychopathologization achieved is now that the trans identity is healthy, we can celebrate it. And it's not just that we can celebrate it, it's that we must celebrate it. If you don't celebrate it, you're a bad person. So then all of these trans celebrities around 2013, 2014 start to appear on the cover of magazines and television shows. They're all over the place and everyone's celebrating it. And I believe that triggered the social contagion of adolescents struggling, muddling their way through puberty. They hate their body. They don't understand why. They're offered this cultural script. You hate your body because you're trans. So then they adopt this trans identity, and then they find themselves in the hands of a medical world guided by WPATH that has removed all of the guardrails around this treatment, these hormones and surgeries that have no science and no evidence to back them up. It's this horrible, deadly, dangerous, perfect storm.
Wow. Wow. That's amazing. So wrote a whole bunch of notes. So I apologize that the summary of what you said might be a little longer than I might prefer, but I love the concept of overvalued idea. Brilliant. And your distinction between it and an obsession or a compulsion, we usually call them ego dystonic. We don't like them. We can say, oh, I wish I didn't have this, but I still have to do it. Whereas the overvalued idea
Ego
is
syntonic.
right.
I love those terms. I didn't use them because I didn't know if people that would understand them.
Well, just explain them.
That's the crucial factor. Overvalued ideas are ego syntonic. So
Yes.
this is true. This is in line with who I believe I am. This is a true expression of my deepest, most personal nature.
Yeah.
And therefore, you don't fight against it. You embrace it. You relish it. You cherish it. You act upon it. Anorexia is another disorder it's another ego syntonic disorder of overvalued idea. That the anorexic is not distressed by being thin. The anorexic loves being emaciated and just skin and bone. The anorexic doesn't show up for psychiatric treatment because she wants help overcoming her desire to be thin. She shows up because her family thinks she's going to die if she continues to starve herself. So anorexia is a disorder of overvalued idea. It's how you experience it. And I'll tell you, this is another thing. The remarkable thing about gender medicine is that when they measure success, the way they do it is they basically take a whole bunch of people who have this overvalued idea that they desperately need these treatments. They give them the hormones, the surgeries, and at the end they say, oh, are you happy? And they all say, yes, I'm happy. And they say, okay, well then that means it must be good. And that's like not understanding the overvalued idea. Of course the person is happy. You give an anorexic Ozempic and she's skin and bone and almost dead, and you ask her, is she happy? Yes, she will be happy because she believes that this is who she is supposed to be. This is her true identity. So the same thing happens with gender medicine. You cannot use self-report as a measure when you are not only, you're taking the key desire of the overvalued idea, you're taking the key symptom and you are giving the patient exactly what that symptom demands. And then at the end of it, you say, are you happy? And of course they say yes. And then that's what they base the treatment on. It's a totally flawed approach, of course.
Right. And so when you use the example of anorexia, I was going to use apotemnophilia, but we'll talk about that in 1 second. So with anorexia, everybody knows that, and that word, anorexics can die. They take their egosyntonic, overvalued idea to its ultimate conclusion, and they die. And they're extremely difficult to treat when they're in hospital. I only rotated through that during residency, during training, but I just saw these poor people, and exactly to your point, they're taking out their IVs and pulling out their they will do whatever they can to stop you from helping them end their life. And they actually don't want to end their life. They're not there saying, I want to die, but they are so obsessed with this overvalued idea. So related to this, though, the reason why I mentioned apotemnophilia, it's just a fancy word. I don't know if I've even pronounced it right, but it's where people get satisfaction, or we often would describe it as sexual arousal, but I think it's deeper than that. They become, again, obsessed, like you said, an overvalued idea with the notion that life would be better without a body part, let's say their arm or their foot. And in fact, they might even go so far as to cause injury to a body part to finally get to a point where a surgeon has to take it off because it's infected, it's gangrenous, and okay, now they achieve what they've been wanting, and no one has done it because no one's going to say, not going to take off your healthy arm. So that's apotemnophilia. But you mentioned that especially in the early days, people were doing mastectomies, so taking off breasts, penectomy, taking off people's genitalia without evidence. And yet we're guided by, like, we take an oath, do no harm. A lot of people don't take that oath anymore, but we're guided by standards of practice and a medical community that says, yeah, no, we're supposed to save life and limb. And so that's why we exist. How did this even get going where it would be like people saying, oh yeah, no, we've now created a community that believes we're doing the right thing by taking people's arms off because that's what they want. And look, we have that data. We have research showing that they are happier. They go back to work. They no longer obsess about their arm that they didn't want. So clearly we are doing a good thing. So I've thrown out a whole bunch of things. Standards of practice, what determines what medicine, or who determines what medicine is, what is good, how do we even measure outcomes when we talk about research? Because this has been my criticism of not you, myself, you and me, and some of our friends who are thinking in this community. I've raised the issue that, well, if we just battle evidence, someone's going to come up with research saying, look how happy these people are. And so I don't know that taking this approach of demanding evidence that people are happier afterwards is the right way to go. So I've laid about 4 different paths down for you to go. Pick whichever one you want and take it away.
I first of all agree on the evidence. This has been my thing for a long time. I had this, that's tied in with Gordon Guyatt, whom we can come back to later, but I had this when McMaster produced a systematic review that ended up being massively controversial, but there's just another systematic review saying there's no evidence to do, there's only low to very low quality evidence for these interventions on adolescents. And I just thought, how many more systematic reviews are we know there's no evidence? You want to keep assessing the same pile of garbage junk science and concluding that there's no evidence? This is not getting us anywhere, which is why I came up with this overvalued idea, this entire new framing. Because, first of all, to the people in the field of gender medicine, telling them there's no evidence means nothing. They don't care about the evidence. There's never been evidence. That's not how they work. They're guided by this idea. They're guided by an ideology, and they believe that they are saving lives. And evidence, I know Marcy Bowers, former president of WPATH, has said, oh, the evidence is on the way. It's coming. The evidence is always just on the horizon. It will come any day now, and we will prove that what we are doing is right. And they have that mentality. So yeah, focusing on the evidence gets us nowhere. Let's have a whole new fresh look at what's going on and try and help these people. But so with the measure of success, I suppose, the apotemnophilia, I was obsessed with this. I still am kind of obsessed with these people who want their limbs chopped off. It, of course, comes down to how you're defining harm. So there's 2 camps in this. There is the traditional sense of harm in the world of medical ethics, where you don't cut into healthy bodies. Cutting into healthy bodies can quite easily be defined as harm. But then with the apotemnophilic people, the people who want their limbs chopped off, and with trans-identified people, there's a different definition of harm. And the definition of harm is not cutting into the healthy body, because then if you do not do this, whatever surgery this individual so desperately desires, they will suffer psychological torture for the rest of their life. And this will be terrible pain and unimaginable suffering. And crucially, you are absolutely correct that the apotemnophiles will try and amputate their own leg. Prior to gender medicine being widely available, trans-identified men did try and cut off their own penises. Some of them actually did cut off their own penises. This is how powerful this drive is. And I suspect for apotemnophilia, it is a paraphilia. There is a sexual desire. They want to be amputees because that is their sexual fixation. And for a certain subcategory of trans-identified people, it's the same thing. It's just a different set of body parts. Autogynephilia is the kind of sister paraphilia to apotemnophilia. Autogynephilia, the man is erotically fixated on the fantasy of possessing female body parts. He hates his penis, he wants a vagina, he wants breasts. I think there is such an obsessive fixation on obtaining the sexual desire, like a male sex drive when it fixates on something. It can result in the man chopping off his penis. It can result in the man trying to chop off his own leg. And so I actually understand both sides. To me, obviously, the traditional do no harm in a medical ethics sense is clear. But I do also understand that these individuals are doing themselves harm. The problem I have is that I don't think a field of medicine is safe if its guiding ethical principle is the patient saying, give me what I want or I will hurt myself. Something's gone terribly wrong. You're being blackmailed by your patients, basically. If that's the way that your field of medicine proceeds, you're being blackmailed by the patients.
So that's just a shiny object for me. I apologize. I had to raise my hand and jump in there. But you are describing modern medicine. This is modern medicine. I want medical assistance in dying. You must give it. I want you to refer me for gender transition. You must give it. We could put abortion in there. I want an abortion. You must give it. I'm not going to talk about abortion right now. Hopefully you don't go down that trail, but you are describing modern medicine where if it exists, if the technology exists, then not only should we offer it, but we must offer it. So unpack that, because on the one hand, we're criticizing the trans activists for driving this, but that's what we've been telling people for 50 years. Yeah, medicine's here to give you whatever you want. So go ahead.
Sorry, I choked on my tea there, but I'll try. I'll do my best. Hang on.
So while you're choking and catching your breath, I'll say we could also throw in cosmetic surgery. I want to have gigantic lips, so I'm going to get injections. I want to have large breasts or buttocks, or I want to have calf implants too, because I'm a bodybuilder and I can't develop my calves. So we give people what they want there. And we can do it. Why don't we just give people? And again, I'm not agreeing with this. I'm just trying to get you as excited as possible and make you choke on your tea.
So it's the consumer-driven approach to medicine, the sort of, you're right, it's been around for about 50 years. There are problems in all. No, medicine should not operate on a consumer-driven approach, I agree. And so medical assistance in dying, I just don't understand. I don't understand how we got this slippery slope into, obviously it was always going to happen because Canada is nothing but slippery slopes, it seems. But I think there's something unique about gender medicine. So first of all, you can compare it with cosmetic surgery. And cosmetic surgeons did at one time, I believe, have some sort of ethical guiding principles that they seem to be abandoning in the modern era, also in the sense that they would typically, body dysmorphic disorder would be a contraindication and doesn't seem to be so as much anymore, although they claim that body dysmorphic disorder is a contraindication. But credit to the plastic surgeons in that the American Society of Plastic Surgeons is the only professional medical association that has taken a stand on gender that is courageous and grounded in actual medical ethics. So I don't want to diss plastic surgeons too much because I really do greatly appreciate that they took this stand. However, if you take cosmetic surgery as your comparison, I would say there's more caution in the field of cosmetic surgery that does not claim to be medicine. It is consumer. It's all consumer driven. You go in, you pay for it. It's not improving your health at all, and nobody is claiming that it's improving your health. The problem with gender medicine is they are not only claiming that it improves the health of these individuals, but they're claiming that it's life-saving. And that's a lie. There's absolutely no evidence to say that this is life-saving. It is life-saving in the sense, if you base your entire field of medicine on give me what I want or I'll kill myself, then giving what they want, you can understand the logic behind it, why they think it's life-saving. But the actual completed suicide rate is not very high in the pre-transition time. It's not very high throughout the transition process, and it is rather high after medical transition is complete. We have long-term studies that show that people who have gone through this entire medical pathway, got to the end, do have an extremely elevated completed suicide rate. So the very idea that you could call it life-saving is completely absurd, and it's just a trans activist talking point. So there's something just, yes, a lot has gone wrong in medicine in the consumer-driven approach, but there's something specially ridiculous about gender medicine. It is completely, every single aspect of it is built upon a lie. It's built upon activist slogans. It's built upon, it is an entire field of medicine that the disorder, if I am correct in my framing of trans as an overvalued idea, and the disorder itself, the key symptom of the disorder is wanting extreme body modification, and the treatment is extreme body modification. The symptom and the treatment are exactly the same thing. So there's something just uniquely absurd about the entire field.
Yeah. So I apologize. I'm raising my hand too much. I said I would only raise my hand when I want to cut in, but I'm worried that we're going to run out of time. And there are a couple more really exciting questions I want to ask you. But so again, I think you've come right to the point of the spear here, or the crux of the issue. I feel my problem is X, and the solution to my problem is to treat X. Who are we? And I'm on your side, by the way. I think that we shouldn't do that. I think that medicine does have a purpose to save life and limb, to help people who are going to be a risk to themselves. That's how I was trained. That's how I believe. I've cared for many, many patients that they thank you later. Thank you so much that you didn't let me kill myself when I was suicidal or whatever. And you're saying there's evidence to show that, intervening in these cases actually doesn't make a whole bunch of happy people afterwards. However, you and I are in agreement on this, and so I'm trying to find a way to argue with you. So what if it's consumerist medicine? So what? Our whole society is that way. We are a liberal democracy, and we believe that your desire and your wishes are the fundamental basis of the freedom in our Western democracy. And now you're trying to convince me that, well, in this particular case, we're not so pro-freedom. We're not so pro-expressive individualism. We actually don't believe in individuals. We believe society has the right to say, you can go this far, but no further. So I've tried to steelman the argument, which you've probably argued against many times. How would you respond to that? You're being anti-liberal.
That is actually not how medicine works. First of all, apotemnophilia is a thing, and yet we're not chopping off legs left, right, and center. You can't just walk in and say, I'm supposed to be an amputee, chop my leg off, and somebody will do it.
For now.
I mean, Canada did chop that guy's fingers off. Did you see that in Quebec? They chopped, a man thought he shouldn't have 2 or 3 of his fingers. He's like 22 years old, and they chopped his fingers off. Okay, you can't walk in and say, I have breast cancer, get rid of my breasts. No diagnosis, you just self-diagnose. That is actually, even in a liberal, open society, that's not how medicine works, okay? We don't just self-diagnose and demand whatever surgeries we want. And if we want to maintain some kind of level of medical ethics, do no harm, then we're not going to go in that direction. It's worth fighting to protect a field of a medical world that actually does restore health and protect patients. And so trans is, again, it is unique. I don't think there is a parallel. I don't think anybody self-diagnoses, walks into a clinic, demands treatment and gets it. I can't think of any other branch of medicine. And especially we're doing it to children. We're doing it to 11-year-olds, 12-year-olds, 13-year-olds. My point is, I'm always accused when I did that talk and I framed trans as, you can call it an overvalued idea, that actually the modern term is the extreme overvalued belief. And so I was using the modern term. But when I framed trans in this way, the backlash was so enormous. People were so upset. The trans activists, they thought that I was on some kind of extermination campaign or something. But my point is, I think that the people who identify as transgender deserve better care. I don't think that they are helped by being given exactly what they think they want, because we have seen, I mean, next week I'm flying to DC. I'm speaking in the Capitol, on Capitol Hill somewhere, the Detrans Awareness Day. Now, the number of detransitioners that we are seeing, they are everywhere. They're coming out all the time. There's so many, and they're all telling their stories, and the stories are all very tragic, and they're all kind of the same. They just, young people in a terrible place in their life, they locked onto the trans belief. They believed themselves to be trans. It felt completely natural. They felt that the only way to solve their pain and suffering was to have these body parts chopped off, take these hormones, and then they got to the end and they realized that it was actually all false, and they are not any better off. The mental health issues that they had before that led them into the trans belief still exist, and now they're dealing with them in a medically altered body. They probably can't be parents. They'll never breastfeed. Some of them, the men don't even have penises. So we are talking large-scale iatrogenic harm. We are talking large numbers of young people being harmed by the medical world because it is this transition on demand. It's just giving people what they want because they say they want it. And so when I came up with this new framing of trans as an overvalued idea, the idea is not to exterminate trans-identified people. It's not to cause, I think it's that it will provide safer care, because the professional who encounters this individual will understand what is guiding them, what is driving them, what is going on. And the individual themselves will understand what is motivating them, instead of believing themselves to be a type of person that doesn't exist. That right now they believe that they are trans and that this is an innate, healthy type of person. Instead of believing that they're a type of person that doesn't exist and pursuing radical body modification in the service of that belief, understand why you've come to this conclusion. Understand the cultural moment that gave rise to this belief. Understand what you're caught up in. And I have much more to publish on the issue, but my basic conclusion is, I'm not saying that this medical treatment should be banned. I'm not saying, I'm making no comment on that. But I am saying that the medical professionals, if the individual continues in this harmful pursuit of medical treatments and actually undergoes them, you should view that as a therapeutic failure. You have failed to loosen the grip of the belief. You have failed to get the individual to reconcile with the body that they have, and you have failed to avert the need for this person to be turned into a lifelong medical patient. I'm not saying it has to be banned, but I'm saying the focus of treatment, I know trans activists are very upset about this, but the focus of treatment does have to be on the belief and loosening the grip of the belief and getting the person to relinquish the desire for these treatments. It's just, I think that's a safer, more ethical approach.
So that is fascinating. So you wouldn't ban it, but you would try to encourage people not to take that path. So that's an interesting middle spot. You're still upholding this liberal sense of the individual is the ultimate agency in their life, and they should be allowed to do it, but we're going to try to convince you to not. So that's fascinating. We could have a whole podcast just on that. I wanted to say, though, that, and this has been my position on this whole issue from the start, is as a clinician, my job is to ask questions. And I published an op-ed several years ago when this was just, I think it was 2022, after much encouragement from Brian Lee Crowley. And the best I could come up with is I said, Brian, I think the safest moral high ground in this issue is the assumption of no questions asked. Doctors are not allowed to ask questions when someone presents with this concern. So if you came to the clinic and said, I have chest pain, I think I'm having a heart attack, I would immediately say, well, tell me about your pain. Why do you think it's a heart attack? You'd go through the questions. But then I'd also ask you questions about, have you had a pneumonia? Could it be a blood clot to your lung? Are you having a tearing in your aorta, the big vessel in the center of your chest? And so I would come up with a differential diagnosis. That's how medicine works. You ask questions. If someone's coming asking for euthanasia, medical assistance in dying, I say, well, why do you want that? What are you scared of? And I would explore their thoughts and desires and what is their sense of what MAID is all about. And then I would say, is anyone pressuring you? Do you have a gigantic insurance policy that someone is going to cash in on? Are you feeling a burden? Yeah, my son is not treating me well. And so that's the job of the professional if you are focused on the interests of the patient. And so I just throw that out there for you. I think you probably already agree, but I think the moral high ground exists on saying it is best for patients if we not only insist, but we demand that the medical community do their job and actually ask questions and explore alternatives. And it can, in the same way they would with anything else. Sorry, you look like you're dying to jump in. Go ahead.
I'm dying to leap in because I swear, like my whole new framing answers everything, including this. Why no differential diagnosis? Why no investigation into the cause? Why is it that the person walks in self-diagnosed, I want this medical treatment, here you go, there you have it? And it's because of de-psychopathologization. It's because of WPATH. It's because they try to make trans like gay. So a person walks in and they say, I'm gay. And it's not like, oh, well, why are you gay? What happened in your childhood? Because we've de-psychopathologized. It's not a condition that needs to be treated. So we're taking trans as if it's some kind of innate healthy trait. And if it's innate and healthy, why would you do differential diagnosis? Differential diagnosis suggests that you've got a psychopathology and you're trying to figure out, could it be this one or this one or this one? What other diagnosis would fit? It's not a diagnosis. It's a healthy, natural state of being. Okay? So that's why I want to re-psychopathologize, because de-psychopathologization is truly the core of the medical scandal. It is, you are denying the existence of someone's psychiatric disorder doesn't help the person who has that psychiatric disorder. It doesn't help them understand themselves. It doesn't help them overcome whatever challenges they're having. And this is a case of the person has the psychiatric disorder, you deny it completely, you pretend it's perfectly healthy, but you affirm the key symptom, because the key symptom is the desire for the medical treatment. And you are saying, yes, this is what you need. This key symptom, this desire for the medical treatment is going to save your life. You need this medical treatment. If you don't get it, you'll kill yourself. That's actually the messaging of trans activism. So it all stems, you can't do differential diagnosis for a healthy state of being. You can only do differential diagnosis if you recognize that you're dealing with a psychopathology in the first place. But one last thing. With my framing, you can tell I'm really excited about it.
Yes, that's good. That's good.
If you show up and you say, I am trans, I want this medical treatment, and the person who encounters you frontline realizes that this is a person in the grips of an overvalued idea. They believe themselves to be trans. It is an overbearing belief, and they believe that they need this medical treatment. The individual who first encounters you, the therapist, it is their job to then find out why this individual was susceptible to adopting this idea. The idea is the pathology, the belief is the pathology, the psychopathology, but there are reasons why an individual is susceptible to the trans belief. It can be on the autism spectrum. They can be autogynephilic. They can have an internalized homophobia, and they don't want to be homophobic, or they experience persecution and discrimination because of their gender nonconformity. It can be they've experienced trauma. There's, like, even back in 1892, when Karl Wernicke first outlined this, he says it arises in an individual of sound mind, but normally following some kind of emotional event or a series of emotional events. And so he understood that there are factors in a person's life that make them susceptible to becoming fixated on one idea. So if we reframe it as that, we recognize that the belief, the idea itself, is the psychopathology, then it becomes the job of the professionals to figure out what in the person's life made them susceptible to this belief. What is this belief a solution for? What is this belief? Why have they latched onto this belief, and why do they think that this medical treatment is the answer? So you've got to start with the belief and then work backwards. You have to do your differential diagnosis. Right now, we start with the belief, we affirm the belief, and we give the person precisely the pathological treatment that they so desperately desire.
Yeah. I like how you've said that, and I'm going to push back a teensy bit. I keep trying to think, how can I find a way to argue with you? So I think you could separate the de-psychopathologization. That's a mouthful. And thank you for telling me how to pronounce apotemnophilia. So there, I learned that too. I was pronounced at the wrong emphasis, accent on the wrong syllable. Anyways, de-psychopathologization. I think there's work and argument, and you're writing a paper on that, and that's an exciting topic on its own. And even if we put a pin in that, leave it to the side, we can still ask for people, not ask, demand, teach medical professionals to ask questions and come up with differential diagnoses. Even when someone comes in who has a symptom that turns out to be normal. I feel like I have too much air in my chest, doctor. Oh,
Yeah.
okay. So
Yeah.
do you have this hyperinflated lungs? Do you have Ebola? There's something wrong with the lung tissue. So we still come up with a differential diagnosis, even if the symptom that they're saying turns out to be an entirely normal, non-pathological symptom.
Yeah.
So I would say that you could potentially separate those two things and still take the moral high ground of demanding questioning, demanding a different formation of a differential diagnosis. And I know that sounds authoritarian, but that's the basis of a profession. If someone says I'm a professional, then a professional is held to a set of standards. You have a duty to behave in a certain way. And one of the core duties, I think, is asking questions, forming differential diagnoses, separate from how we view a particular diagnosis. Your symptom may be natural and normal. And so I'll just throw that out there for you. But I have two more questions I want to ask. If you want to comment on that, go ahead. I know you're watching the clock. I don't know how much time you have left.
I am. It's because I have another interview. So I've got about 5 more minutes, and then I have to
5
go
minutes.
and get ready and then get back to my other interview that starts.
Okay, I'll give you both questions at the same time, and you
Okay.
close the show out.
Okay.
I desperately wanted to hear about the Gordon Guyatt story and evidence-based medicine. And then the last question I always ask everybody is, what should I have been asking you about? So what have I completely missed the boat on? So Gordon Guyatt, and what should we be thinking about? Go ahead.
Gordon Guyatt. So this is there are misconceptions around this massively viral clip of an interview that Stella O'Malley, my co-host, and I did on our Beyond Gender podcast with the godfather of evidence-based medicine, Dr. Gordon Guyatt of McMaster University. So there are misconceptions in the sense that a lot of people think that it was all deliberate, that I deliberately lured this man in so that I could humiliate him on my podcast, and that is not true at all. We interviewed him last September, and I had invited him for the interview all the way back in May, but he was off for the summer, so we just set a date for early September, and that was that. We were just going to have a really boring conversation about evidence-based medicine. In the intervening months, a whole big controversy exploded surrounding a series of systematic reviews that McMaster University had done into the evidence for pediatric gender medicine. And so, as I mentioned earlier in the interview, that systematic review, they publish it, and the evidence is low to very low quality. Like every other systematic review in existence, they all say the same thing because the evidence is low to very low quality. So there was nothing controversial about it, except for trans activists who will not tolerate any deviation from this is life-saving necessary care. Trans activists start showing up at McMaster, hounding the reviewers, hounding the individuals involved in this systematic review. And then the most pathetic capitulation thus far in the gender debate, and I'm sorry, but I'm not going to measure my language on this. McMaster is the birthplace of evidence-based medicine. McMaster is an extremely renowned, prestigious university, and yet they gave in. They wrote the most pathetic statement. Trans activists had been hounding them, so they basically just write this statement. It was like a hostage note. Basically, we think that the people who funded these systematic reviews are a bunch of transphobes, and we're just a bunch of cisgender researchers. We don't know. They actually use the word cisgender like some blue-haired trans activists. This is one of the most prestigious universities in the world. Then they say, you know, we don't want our reviews to be used in like the bans, the puberty blocker bans, because Danielle Smith had just banned it. And then they say we made a donation to a gal so that they continue their legal work to ensure the provision of medically necessary care for trans-identified youth. That's how it ended. Gordon Guyatt signs his name. He's the first one to sign, and then the rest of the team, except for two refused to sign it. Good for them. And so this all happened in August, and I knew I was interviewing him in September, so I just didn't say anything. It was very difficult for me to stay quiet, but I wasn't luring him in. I just wanted to know, what are you doing? You're just, like, medically necessary. I don't have to tell you, but if something is medically necessary, that means you have to have a diagnosis, and the treatment you are providing has to be proven to be beneficial and effective. If you don't have those things, you can't call something medically necessary. You're just experimenting. You have no idea if you're helping this patient population unless you have proof that it's beneficial. And so when I read the statement, my eyes lingered on medically necessary. How can he have done these reviews, know that there's no evidence, know that the treatment, doesn't even know what the diagnosis is? How can he say it's medically necessary? So we interview him. We didn't think he would show up, of course. I didn't think he would show up. And my co-host and I sat there waiting for him. And then all of a sudden, there he is. And he was quite rude and obnoxious right from the start. He accused me of saying things that I wasn't saying, even at the start, all the way through. So he had kind of annoyed me anyway. Plus the cowardice of signing this statement and torching this systematic review. You know, it's now so much controversy that it lessened the impact of the reviews. And so we get to the end, and my last question was, you know, why did you sign a statement saying that these treatments are medically necessary? And he just, you've seen it, right? He starts shouting at me. He's like, that's ridiculous. He's actually like leaning in, red in the face. He's shouting at me. I'll have to jump off a bridge if you can find those words. And then, of course, you know, my heart was absolutely leaping out of my chest. And I read the final paragraph where it says medically necessary. And the astonishing thing to me is, you see, I would be horrified if I embarrassed myself in such a way in a podcast, but he was rude to me. He shouted at me. He said he'd have to jump off a bridge. And then I proved that I'm right and he's wrong. And instead of apologizing and showing some humility, he turns it around on me. first of all. He says, I'm behaving inappropriately. He says that just focusing on those two words when we should be focusing on the part that he clearly wrote. The part, how are we supposed to know what part he clearly wrote? The entire statement is transactivist garbage that looks like it's written by Canada. Like, no part of it would I ever think the godfather of evidence-based medicine would write. And then he gets angry with me for pointing out his mistake. So I still to this day can't believe it happened. And the other amazing thing to me is not only did he not apologize, he turned it around on me, he was rude to me. McMaster have left the statement up. So this has gone viral. Millions of people have watched it. More than once it's gone viral. McMaster ought to understand how damaging this is to their reputation internationally. And so I gave them a few months to retract the statement, and they didn't. So then I did an open letter to McMaster informing them of what happened in case somehow they missed it, and asking them to retract the statement. And they completely ignored it, and it's still up to this day. Which means one, they don't have any integrity. They don't care about the truth. And two, they are still afraid of trans activists. This all happened because they gave in to trans activists. They gave in to these individuals who show up and harass their staff. These researchers who were just doing their job, and they did their job well. And they're just doing what researchers are supposed to do at the birthplace of evidence-based medicine. McMaster did not support them, did not back them, did not stand up to the trans activists, didn't have them removed from campus, and absolutely, if you're a student there, you get kicked out if that's the way you behave. They didn't take a firm stand. Instead, they were cowards and they capitulated. But now that this has all happened, they're still afraid of them. They won't take down that statement. So
what should I have asked you about?
Oh, goodness. I mean, we covered a lot of ground. This issue, there is so much. We didn't even go from perhaps the Canadian side of it, as we're both in Canada. We could have gone deeper into the Canadian side of it, but I don't know, we've covered good ground. What's the origins of it?
CAS report we didn't talk about, and so there are other things we could have talked about.
Yeah, I mean, to me as well, the social contagion side is a crucial part that really, the reason I love talking about the social contagion side is because everyone understands it. You don't need to get into the technicalities of the diagnosis or the technicalities of the quality of the evidence or the history of it or anything. You can talk about social contagion to literally anyone, any walk of life, anywhere in the world, and they will understand because it is basic human nature. So if you explain the social contagion, and like I always parallel it with bulimia, cutting, TikTok tics, all of the ones that we've seen it's interesting and it's so clear, and we all understand how social contagion works, and we've all seen them in our communities. And then if you overlay that with the trans phenomenon, and you just show the average normal person who knows nothing about this debate, it clicks right away and they understand it, and then they see what a medical crime this really is. So we could have spent more time on that, I suppose.
That is a powerful way to end. Mia, thank you so much. I'm glad I got you excited and choking on your tea, and thank you for your work. I'm looking forward to your article, and thank you for spending your time.
Thank you for having me. It was a pleasure.
Mine too.